Hi, my name is Anthony Wang, and on behalf of our chair, Coy Than, and the rest of the Case of the Month Committee at the Congress of Neurological Surgeons, I'd like to briefly review the CNS Spotlight article, Cranioplasty Reverses Dysfunction of the Solutes Distribution in the Brain Parenchyma After Decompressive Craniectomy, as well as our accompanying Case of the Month.
Our case is of a 42-year-old gentleman who presented with the acute onset of a mixed transportable aphasia and what was initially a mild hemiparesis. While the initial event appropriately prompted an ischemic stroke evaluation, including NIH stroke scale and non-contrast head CT, his imaging identified a large left, primarily temporal intracerebral hemorrhage. At this point, he was awake, interactive, and following commands. Patient's presenting systolic blood pressure was in the 160s, and for most ICH patients, acute blood pressure reduction to 140 millimeters mercury is safe and can be effective for improving functional outcome according to American Heart and American Stroke Association guidelines endorsed by the CNS and the AANS. The patient carried minimal risk factors for spontaneous cerebral vein thrombosis, hypertensive hemorrhage, amyloid angiopathy, or infectious aneurysmal disease. In this setting, interpretation of the CT appearance of the hemorrhage recalls a venous infarction or cerebral AVM rupture, both relatively rare entities as potential etiologies. As such, digital subtraction angiography was obtained, which identified a vein of Labbe occlusion. Hemorrhage evacuation notwithstanding, decompressive hemicraniectomy is recommended by the European Stroke Organization for mortality reduction in acute cerebral venous thrombosis with a large parenchymal lesion causing impending herniation. The expected Conyard type 3 dural arteriovenous fistula involving the vein of Labbe adjacent to the transverse sigmoid junction became visible on repeated postoperative angiography and was initially treated by endovascular embolization but quickly recurred. Hydrocephalus and symptomatic syndrome of the trephined or sinking flap syndrome are common late complications of decompressive hemicraniectomy, both with an estimated incidence on the order of 10%. Both are likely to resolve after autologous cranioplasty, particularly if performed early. This patient underwent early cranioplasty with concurrent surgical ligation of the recurrent dural AV fistula and has since recovered full motor function as well as good speech and language function. One component of neurologic improvement after cranioplasty is hypothesized to involve restoration of metabolite circulation and clearance via the recently discovered glial lymphatic pathway. In a study by Borja and colleagues from Normandy University in France, the caudal to rostral intracranial distribution of gadolinium contrast injected intrathecally at the foramen magnum was significantly reduced after hemicraniectomy and restored with cranioplasty. This finding was true both 2 days and 15 days after surgery. We invite you to read more about this study in the November 2020 issue of Neurosurgery.